Good evening, everyone, and welcome. I'm Jeremy Price, the President of the Board of Trustees of the Westport Library. It's a pleasure to see you all here tonight, and those of you on Zoom as well. First off, can I ask folks to silence their cell phones? We've had some embarrassing moments. I want to make sure it doesn't happen this evening. So take a minute. Thank you. Tonight I have the distinct honor of welcoming the accomplished Dr. Scott Gottlieb to our stage. Scott is a physician and an investor who served as the 23rd Commissioner of the FDA from 2017 until April 2019. He is presently a resident fellow at the conservative think tank, the American Enterprise Institute, a partner at the venture capital firm New Enterprise Associates, a member of the board of directors of both Pfizer and of Illumina. He's also a contributor to the financial news network, CNBC, and a frequent guest on CBS's Face the Nation. Before becoming FDA Commissioner, he was a clinical assistant professor at New York University School of Medicine. He's the author of a new book entitled Uncontrolled Spread. It's about the COVID-19 pandemic and the national security vulnerabilities that it revealed. Dr. Gottlieb recommends that we must be better prepared when another dangerous pathogen emerges and threatens a global pandemic, and equally as important that we secure a greater assurance that a global contagion on the scale of COVID can never happen again. Joining Dr. Gottlieb in the discussion is fellow Westporter and library supporter Allison Cameretta. Allison is a journalist, author, and anchor of CNN's morning show, New Day. In her 3 decades in journalism, she has covered stories nationally and internationally, earning an Emmy Award for her breaking news coverage of the arrest of Roger Stone and the prestigious Edward R. Murrow Award for her breaking news coverage of Hurricane Maria's impact on Puerto Rico. Allison has also anchored several primetime specials, including Tipping Point, Sexual Harassment in America, and The Hunting Ground, Sexual Assault on Campus. Please join me in welcoming Scott and Allison for what shall be an insightful and thought-provoking discussion.
Thank you so much for that great introduction. Scott, great to meet you.
Thank you.
And I've been really looking forward to this. I mean, I get to interview lots of celebrities every day, lots of thought leaders, lots of politicians, and nobody is my husband more impressed with than you. He so wanted to be here, but he has a school event tonight that he's doing duty at. So anyway, I'll recount all this to him. Okay, so before we get into your book, which has been described as riveting and gripping, and it is, can you just give us a status report on where we are today with COVID, with the hospitalizations coming down over the past few weeks? Have we turned an official corner?
Yeah, I don't think we've turned the corner yet. If you look at the national data definitely shows improvement, but it's being driven by sharp declines in the South. If you look at what's happening on a regional basis, you see cases picking up substantially in the West and Midwest. Virginia right now, 90 cases per 100,000 people per day. Alaska has the densest epidemic of any state at any point in the entire coronavirus pandemic. And Montana, Wyoming, Indiana, Ohio, you're seeing cases pick up. So I think that what's going to happen is this Delta wave is going to be highly regionalized. It's going to course its way through the country. The big question is what's going to happen in the Northeast. You're starting to see cases pick up in New England and in the Great Lakes region. I don't think we're impervious here from seeing a Delta surge. It's not going to look anything like what it did in the South because there's higher rates of vaccination here, higher rates of immunity from prior infection, but I think you will see cases pick up. Now, that said, I think the Delta wave will be done coursing its way through by Thanksgiving or thereabouts, and on the back end of this, prevalence should decline. So, we should see cases come down to maybe 20 cases per 100,000 people per day in the winter on the back end of the Delta wave, probably around Thanksgiving. But we're not done with this yet. It looks like it's improving because there was such a dense epidemic in the South. Now that that's dramatically declining, it looks like the national averages are improving.
So meaning that here in Westport, what's the next month going to look like?
Well, hard to say. I mean, I think that cases will pick up. Connecticut right now has about 12 cases per 100,000 people per day. To put that into sort of perspective, during the summer when we hit the absolute bottom nationally, we were at probably 4 cases per 100,000 people per day. So 12 puts us, in among the best states right now, and the vaccination rates in the state are exceptionally high. So, and people are more engaging in more collective action, wearing masks, taking precautions. So it might not be quite as dense and severe as it will be in other parts of the tri-state region. But I do think you'll see a pickup in cases. Now kids back in school, the weather's going to get cold, people are going to go indoors, people will go back to work. So you're going to see cases here pick up. New Jersey's at about 20 cases per 100,000 per day. New York's at about 25 right now. Massachusetts is about 23. So you're seeing it start to creep up. here in the Northeast with the Delta variant.
Do you think that what will Thanksgiving and Christmas and Hanukkah look like?
Yeah, I think Christmas will be more comfortable. I mean, Thanksgiving is going to be a question mark because if you believe my proposition that this is going to sort of course its way through the Midwest, course its way through the Great Lakes region, and maybe the tri-state region is going to be the last to get hit by Delta, we might be sort of either in the throes of it or coming out of a surge of infection. I don't think we get to, Florida and Mississippi and Alabama were at like 120 cases per 100,000 per day when they were in the sort of thick of their epidemic this summer. I think we could get to 40 here. I don't think that we're going to get much above that, but that's going to feel more uncomfortable than it does right now in terms of just hearing about people having infections, seeing outbreaks happening in proximity to your social network. So, Thanksgiving, we could still be taking sort of cautions. I think by Christmas time, we'll have course its way through. And barring something unexpected, meaning a new variant that pierces the immunity we've acquired from vaccination or infection, I think this is the last major surge of infection. It's probably going to be the case that this Delta variant changes over time. We're going to need to adapt our vaccines, probably using a Delta backbone vaccine in the future. But you're probably not going to see a dramatic shift in the virus so that one day there's a new variant spreading around the world that just obviates all the immunity that we've acquired. So the vaccination and the fact that people now have naturally acquired immunity is going to be a sort of backstop against the kind of spread we've seen in the past. This might be our last major surge of infection. And we're going to have orally available therapeutics around the corner too, which is going to be a real game changer.
I do want to ask you about that. So you don't think that there's some other variant waiting in the wings right now?
You don't know what you don't know, right? So that's the tail risk. The more likely scenario is, if you talk to people like Trevor Bedford and some of the genetic epidemiologists, the more likely scenario is that the variants that we're going to have to grapple with in the future are going to be lineages of the Delta variant. That Delta is going to be the predominant strain that's going to evolve. Right now, there's actually 20 different versions of Delta. So Delta is so contagious that you're unlikely to see something that comes along that sort of displaces it, but Delta itself is going to evolve in ways that allow it to evade some of our immunity. I mean, the fact that the virus hasn't found a wholesale way to evade our immunity yet is a pretty good suggestion that it's more difficult than we suspect, given how much virus has been around the world. Remember, what the virus has to do is, the portion of the virus that we develop our immune cells against, our antibodies against, is the spike protein. And that's the protein that it uses to attach to the lining of our cells, to our lung cells. And actually, it's a specific point on the spike protein, the very tip of it. And that tip of the spike protein attaches to something called the ACE2 receptor, which lines our lungs. It's actually in our lower airways, and that's why it has a predilection for our lower airways. But the same features that it uses to attach to our cells are the very features that make it efficient at doing that. And so it's got to figure out how to change the conformation of that tip of its protein in a way that our bodies no longer recognize it, our immune cells no longer recognize it, but still maintain the ability to attach well to our cells. And it so happens that biology is smart, and the features that we develop our antibodies against are the very same features of that protein that it uses to attach to our cells. And so can it pull off that feat? Can it thread that needle? Perhaps. I mean, it's done it partially, but can it do it in a wholesale fashion? It doesn't seem to be able to, because probably as soon as it changes the conformation of that protein in a way that we no longer recognize it, it no longer attaches well, and then it's just not a good virus.
That's comforting. I'm glad. I'm happy to hear that. All right, so let's talk about how we got into this mess. And that's one of the things that your book does so well. I mean, right from the beginning in your book, page 3, on the introduction, you write about how the U.S. botched the response to COVID, basically, even though we had fair warning. So I just want to read a portion of your book. You say, in some respects, we had been preparing for this moment through 3 presidential administrations, starting with George W. Bush. We had a pandemic playbook on the shelf, ran exercises simulating the threat countless times, and developed this strategic national stockpile to store the medical countermeasures that the top experts thought the country would need. But when the pandemic we long feared finally arrived, we were not ready. Many of the plans and preparations turned out to be technocratic illusion. The stockpile lacked key essentials. A lot of what it contained didn't work. It was a metaphor for our fragile response. So why didn't our plans and preparation work?
Well, first of all, we had always prepped for an influenza pandemic, and I had been part of some of the planning back in 2005. That's really when we started to plan in earnest, sort of the modern plan started to get formulated. We were worried about at that time about a pandemic involving bird flu, H5N1. Bird flu was evolving in ways that was becoming more threatening to people. And so all the preparations we made were oriented towards the flu. And we didn't put in place plans that were adaptable to a multitude of different pathogens. What we really should have been preparing for was any respiratory disease that replicates through RNA. And so that if you sort of start with that framework, influenza is certainly on the list, but so are coronaviruses, so is Nipah viruses, a lot of other viruses. The reason why you worry about that category of viruses as sort of a broad concept is because a virus that replicates through RNA has the ability to mutate very rapidly and change its characteristics. And a virus that spreads through respiratory droplets or aerosols has the ability to spread very quickly. And so we should have taken a more global view rather than trying to prep things specifically for flu. And then even the things that we had prepped for the flu pandemic weren't adequately prepared. We didn't have the capacities we need. A lot of this stuff had gotten outdated. The strategy was wrong. We had this concept that we could build facilities and mothball them, that we could stockpile stuff, and what you really needed was a hot base. You couldn't just build a facility and mothball it and expect it to be ready in a time of emergency. So we didn't have the capacities we needed. Just sort of a simple thing, when we did the tabletop exercises, sort of modeling what would happen if a flu pandemic struck, the idea of having rapidly available diagnostic tests, be able to deploy massive testing, was never a big feature of the planning, because with a flu pandemic, the incubation period for flu is very short. It's like 3 days. So by the time you're exposed, you have it. So intervening, using testing and tracing to intervene to break off chains of transmission isn't as effective in a flu pandemic. And also, in a flu pandemic, you're not contagious until you're symptomatic. So getting people diagnosed while they're asymptomatic isn't as important to contain the epidemic. And the nation's installed base of flu testing in every doctor's office would be sufficient, because the installed base of flu testing can differentiate influenza A from influenza B. And if you have a pandemic and you know it's influenza B, and someone gets sick with flu and is diagnosed with influenza B, you know they have the pandemic strain, because the pandemic strain is going to predominate in a pandemic. So we had never really prepped the idea of how do we deploy massive amounts of testing de novo and mass manufacture new diagnostics. Yet the lack of a diagnostic test was at the root of all of our early problems. It plagued us for a full year, the fact that we didn't have testing capacity available for COVID. And it's what forced us to be so badly set back in the beginning, and I think was the root of a lot of the political acrimony as well.
As you outline in the book, you were in touch. I mean, in the early days of the pandemic, you were talking all the time to people in the Trump administration and to Congress and to the pharmaceuticals. And I mean, were you, at what point did you realize that, sorry, I thought that was my phone. Is that my phone, Mom? Mom. Mom, just handle this. This is just a little window into our life here. Can you just turn it off? Sorry, Scott. It's how unprofessional my phone. Did you get it, Mom? That's my mom. Okay, back to the question. Because you were on the front lines of all of this and watching it all unfold, I mean, at what point did you realize, everything that we had planned for isn't working? I mean, at what point did the panic start to hit and you realized that the U.S. was really ill-prepared?
Yeah, I was probably late January. I started to write a series of op-ed articles talking about the diagnostic testing and the fact that we needed to sort of crash the production of diagnostic tests. And I was sort of laying out a framework for what I thought we should be doing. I started to get an awareness that we weren't doing that probably in late January, early February, when I saw the response of what the administration was doing. The first moment that I really had was on Martin Luther King Day weekend, when the reports out of Wuhan were that the number of cases went from 50 to 200, and all 200 people were hospitalized with severe pneumonia. And that alarmed me for two reasons. Number one, quadrupling the number of cases that they're reporting overnight was deeply concerning, because the Chinese government's probably not being fully forthcoming with the data. And a respiratory pathogen that only presents as severe pneumonia is very unusual. I mean, SARS-1 presented that way, but SARS-1 didn't spread with that velocity. So what it suggested was that the number of cases must be hundreds, if not thousands, of what's being reported, and all they're seeing are the people who are showing up in the hospital sick enough to require hospitalization and admission to the intensive care unit. So I actually called, that morning I called, texted the head of the Domestic Policy Council in the White House and said, told him how concerned I was, and then suggested that he pull together a briefing for the different operating divisions. He reached out to the Secretary of Health and Human Services and get the FDA and CDC starting to work together. And that was really around the diagnostic test. And I specifically talked about, the ability to start developing a diagnostic test in some of those exchanges. And he, to his credit, I mean, he was concerned all the way through, but he reached out to the Secretary that day and asked for a briefing. And that was the day that the Secretary famously called President Trump while he was on the golf course. And the Washington Post reported that, and he briefed him for the first time on COVID. And the Washington Post reported that he had gotten a tepid response, and the president berated him for some of the policies around vaping. I don't know that the request for the briefing instigated the secretary to call the president at that point, but that was a sequence of events that happened that day, and then they had the briefing that Monday. The National Security Council had been engaged already, but that was the first point that the Domestic Policy Council had gotten engaged.
And so the National Security Council is engaged because you start to realize that this is going to be a security
Well, the National
problem?
Security Council would be the first office in the White House that it would land on their desk. And there was someone inside the National Security Council, the deputy on the National Security Council, Matt Pottinger, who I write a lot about in the book, who I was also in touch with, he had been a reporter for the Wall Street Journal. He had broken the stories about SARS-1, and he had seen how the Chinese government concealed that information. So he had his own biases, and he was very worried about this early. In fact, he started to wear a mask to the White House, was ridiculed for it, bought masks for everyone on the National Security Council. He moved his office out of the West Wing, his own act of social distancing, because he felt the precautions were so lax in the West Wing that he was worried about getting infected, and put in place a policy that him and the head of the National Security Council wouldn't meet in the same room for the duration of the pandemic, because they didn't want both of them to be at risk of getting infected. So, there were people who were very worried about this early on. He was one of them, and I suspect that's why the NSC got involved early, was because of Matt's concerns around this. I had some subsequent meetings with folks on Capitol Hill. One of the most interesting days I described in the book was I had a meeting. Liz Cheney invited me up to brief the entire Republican caucus. It was right before they were going to pass the stimulus bill, and she was trying to build support for it. And I briefed the entire Republican caucus. I mean, we were all crowded in this little room in the basement of the Capitol, and I was just terrified. This was early March, and at this point I thought that there was widespread community transmission, had been saying that. The only precaution they took that morning was they, instead of allowing people to get their own coffee, they had someone serving it. So you limited how many people were touching the utensils. So I briefed the Republican caucus, and I was pretty downbeat. I mean, I think I was downright scary in that meeting. And then that afternoon, I went and I briefed the Progressive Caucus of Congress. I went from the most conservative members to the most liberal members in the same day. It was pretty stark. I think there was apprehension on the Hill at that point, but I don't think anybody really had a sense of how bad it could potentially get.
But just out of curiosity, were there different precautions being taken in the, conservative caucus and the progressive? Was anybody wearing a mask? Was anybody social distancing?
No one was wearing a mask, but in the progressive caucus meeting, now mind you, it was a smaller group, but they were socially distanced. Not in the Republican meeting.
I mean, Exhibit A of the politicization of all of this. How everybody, depending upon how you vote, I guess, or how you identify, you treat this differently and see it differently. Has that happened before? I mean, has COVID been the most politicized virus that we've had? Have you seen this level? Well, not this level. Have you seen something like this before?
No, but we've never seen any event in sort of recent memory, modern times, where a public health event had this magnitude of impact on people's personal lives. And, there were groups that were disproportionately hurt by this virus. There were groups that were disproportionately impacted clinically by the virus. Clearly, the infection, seeped into cracks of inequities in our society and hurt certain people much more than others. But the mitigation that we adopted also hurt certain people more than others, people who couldn't Zoom in from work, people who ran small businesses and had to shut their small businesses. So I think, because of the magnitude, the impact that this had on our lives, it was inevitable that this was going to end up becoming part of a political debate. I think what was corrosive was we didn't have the ability to really consistently agree on a common set of basic steps that we would take to try to control the spread. And if we had aligned behind that and had more uniform political support for a common set of actions, I think we would have had a pandemic for sure. I'm not sure it needed to be this bad.
Well, I'm wondering about that. Is there one thing you could put your finger on that if we could change, or if you could have changed at the time, we wouldn't have had 700,000 Americans die?
Well, I'm not sure that there's one thing that would have had a dramatic impact on that. I mean, there's a lot of things that could have had an impact on that collectively. But the one thing I think that was deeply regrettable was that we couldn't agree to wear masks. We couldn't get high quality masks to consumers. We didn't educate people about what the masks could afford them. I was involved in the early debate around make a recommendation for masks. So I was having discussions with the task force, the coronavirus task force. When we had put out a report, I'd partnered with some people at Hopkins to put out a report on how to reopen the economy after the shutdown. And one of our recommendations was people should wear masks. We made a recommendation in the report for cloth masks because we had done some work with the distributors and found out there just wasn't enough medical masks. And the reason why we recommended the masks was because we knew that a lot of the transmission was from people who were going out who were asymptomatic and spreading the virus. And there was data that we had gotten from OSHA, CDC's OSHA division, that showed that if you're wearing a cloth mask in the setting of influenza, it cuts down on your risk of transmitting it by 50%, which is just a dramatic reduction from a simple intervention. So the idea was that if we recommended that everyone wear masks when they go out, for those who are asymptomatic and likely to become super spreaders unknowingly, if they had a mask on, they'd be less likely to spread the virus. And this is when we still thought that a lot of the transmission was through droplets. So the idea of the mask was not to protect people who wore the mask from getting infected. It was to protect other people from someone who was infected. We didn't communicate that to the public. And the reason why the coronavirus task force resisted it initially in my discussions was they were at the time recommending that people stay home. And so they felt it would be a mixed message that if they said, stay home, don't go out, but wear a mask, they're basically saying it's okay to go out as long as you have a mask on. They were worried about that mixed message. So it was a lot of challenges with basic risk communication that I think stymied some of the early efforts. But that was sort of the early genesis of the masking. And then we didn't explain to the public that the masks really were to protect other people from you, and that if you want to afford yourself a measure of protection, you should be wearing a higher quality mask. A cloth mask is probably about 20% protective to you. A level 3 procedure mask, probably about 40%, and an N95 or KN95 mask, 95% if you wear it properly. We never educated the public about that. And we never got high quality masks to vulnerable people, which we could have.
But so you're saying that if more people had masked right from the get-go and still now, that maybe we would have?
I think it would have had an impact. I mean, there's enough data right now that the masks have an impact on spread. Look, people who use masks effectively in medical settings protect themselves. I mean, I wore N95 masks and took care of a lot of tuberculosis patients and other patients with respiratory pathogens, never got infected. They're hard to wear. You have to be fitted properly on them, but even if you're not fitted properly, it's still going to afford you a measure of protection. So, if we had gotten a measure of alignment around that, it would have been more effective. And, towards the end, you had this disdain for it, particularly in the White House. I mean, I had these discussions with officials there why they couldn't, get the president, get others to be more supportive of basic interventions like that. And I heard various reasons. The one I talk about in the book is the president thought they looked funny. That was, and then you had President Trump ceremoniously taking off his mask on the balcony of the South Portico when he was still infectious with the virus. What message does that send?
I mean, what did you think when you saw him do that night?
I think that there were some of us. By that point, I wasn't really having a lot of conversations with the White House. I was talking to them probably through March into April, and a couple times after that. But I think past April, the advice I was giving wasn't
Welcome.
it wasn't aligned where they were heading. But I think that there were some of us who thought maybe after the president's bout with COVID that he may come out sort of with a different, a different perspective and a different message, and he didn't. And that was a very big missed opportunity from a public health standpoint, very big missed opportunity.
One of the things that you talk about in the book, and you're quite unsparing in your criticism, is the CDC and the mistakes that they made. So do you want to just take us through a couple of their biggest mistakes?
Yeah, look, the CDC was the wrong agency to quarterback this response. I think, and this was a failure of political leadership as well. The political leaders had this idea that the CDC would be able to operationalize a national response to a crisis of this magnitude, that they would be able to develop and manufacture a diagnostic test and deploy it, that they would be able to gather information on a real-time basis, do real-time analysis, and provide analytical recommendations to policymakers on an ongoing basis. And the CDC has the capacity to do none of these things. They don't have the culture to do it. CDC is a sort of deeply analytical, very retrospective organization, does high science. They would much rather take 4 months and be the definitive word in answering a scientific question and then publish it in the MMWR and do peer review. They're not the Joint Special Operations Command that can take in reams of information, do analysis, and inform policymakers on an ongoing basis. They can't mass manufacture a diagnostic test. They were asked to do all these things, and they shouldn't have been. We should have tried to create some hybrid entity that combined the scientific expertise with the CDC, with maybe FEMA and some components of the government that had more of an operational capacity. Nobody had the vision to do that. And CDC, to their discredit, didn't raise their hand and say, look, we don't have this, we can't do this. I talk a lot about the diagnostic test because it was at the root of a lot of the early problems, but I also think it's a metaphor for the challenge with asking CDC to do this. So CDC was asked to develop a diagnostic test of SARS-CoV-2. They had access to the early samples, the ones that we know about. In order to really develop a diagnostic test, you need to sample the virus. They held on to those samples, wouldn't provide them to other labs or manufacturers who wanted to make tests. They actually didn't start providing it until the end of February, really 2 months in from when.
And why wouldn't they share that?
Because they're very parochial. And so they developed their own diagnostic test. They contaminated their lab, so they contaminated the diagnostic test. They were running samples. They were testing patient samples in the same lab they were assembling a diagnostic test. And what we think happened is some of the viral RNA from the patient samples seeped into the diagnostic test. I mean, they were violating basic protocols of good manufacturing. So when they deployed their test didn't work. What really needed to happen, I mean, even if CDC had gotten their tests working perfectly, the game plan was that they were going to deploy diagnostic tests to the nation's 100 public health labs. Each public health lab can run 100 tests a day, so that's 10,000 tests a day. We needed 1 million tests a day, not 10,000. So even if CDC had done this perfectly, we still wouldn't have had enough testing capacity in the country. What needed to happen was someone in January needed to pick up the phone and call the major manufacturers of diagnostic tests in the major labs and say, we need you guys to get in this game. You've got to start mass manufacturing tests. We're worried this can become a pandemic. That phone call wasn't made. As best I could tell, that phone call didn't get made to February. And I'll give you sort of one example of how things sometimes work. After Hurricane Maria devastated Puerto Rico, and you were there, there was one major manufacturer that makes bags for blood collection, basically the plastic bags that you use to collect blood. And it was offline. It was offline, everything was offline, but this facility was offline because we couldn't get the oxygen plant, Lincare, restarted on Puerto Rico. We didn't have enough power to restart this oxygen plant, and oxygen was a component in manufacturing these plastic bags. This was right when the massacre happened at Mandalay Bay. And after you have a mass shooting event, you typically have a rush of blood donations in the country. And we were extremely worried there was going to be a shortage of these blood bags, and we would have a cascading shortage of blood in the country. So I called around to manufacturers that made plastic bags for other blood collection purposes and managed to get some to agree to repurpose their production lines to start manufacturing bags for the collection of whole blood. This happens all the time, where you're running a federal agency, you see a crisis, you start calling manufacturers to step in to try to mitigate a potential problem. And manufacturers, by and large, respond to those phone calls. If there would have been some push to try to get the major manufacturers of the diagnostic tests into the game early, they would have done it. As it were, not only did CDC not provide the viral samples to the companies that needed them to make their tests. But if the companies wanted to use CDC's test design, so the companies couldn't come up with their own test design because they didn't have the virus. So the only thing they could do was use the CDC's test design, and if they wanted to use the CDC's test design, the CDC made them license it and put in front of these companies onerous IP agreements. And the companies, it took weeks to negotiate IP agreements with the CDC because the CDC wanted to retain its intellectual property and its patents on its tests. So it was a sort of a catch-22. You couldn't make your own tests, you couldn't use the CDC's test design. And so there were a lot of companies I talked to over the time period said, we're going to just wait and see what happens. You know, CDC said they have this, we're going to see if they really have it. And we never had enough testing in the market. And not only, and this is a final point, I'm sorry, not only did the lack of a test prevent us from being able to identify the early spread. And we didn't know how heavily seeded the country was becoming, but we didn't know where the spread wasn't. We didn't know where the spread was, but we didn't know where it wasn't. And so when we did the 15 days to slow the spread, basically an extraordinary national shutdown of non-essential activity, and then followed by 30 days to slow the spread. I mean, a historic shutdown of non-essential activity in this country. Did we need to shut down Bozeman, Montana, and Houston, Texas, and parts of the South? The virus probably hadn't arrived there yet. You probably could have still used testing and tracing as a way to control the spread. But instead, we shut down the whole country because we didn't know where the virus wasn't. And when the virus finally arrived in those parts of the country, because this was a highly regionalized epidemic at first, the people there said, look, we shut down already. We're not doing this again. And so you lost the political support for the mitigation when you actually needed it because we had to shut down too early because we were blind to the early spread.
Wow. You're not instilling a lot of confidence in the CDC. And I'm just wondering, have they learned this lesson? Has anything improved since then?
I think we understand what the shortcomings are. And I don't advocate creating a new agency. That's always the fool's errand in Washington. I think we're going to need to reform the CDC and give them different capacities. But they just they don't have the capacity to do this. I think there's sort of an illusion that CDC has the capability to respond to a public health crisis, that they're sort of FEMA of public health, and they're not. Most of what they do over time, more of the CDC has shifted towards the disease prevention mission, smoking cessation, preventing heart disease, and away from disease control. And much less of their work is really focused on more of a national security prerogative. Early on, the Epidemiological Intelligence Service, EIS, that's the famed part of CDC where people go in with the spacesuits and collect the samples in an outbreak in a foreign country. When that was formed in the 1950s, it was a very deliberate decision to put intelligence in the title because the early architects of CDC wanted the agency to be seen as part of the nation's national security infrastructure. CDC does not see itself that way anymore, and I think we need to build that back into the organization. So it's going to take different kinds of components, different kinds of people, different culture. Even with something like a collection of information, CDC gets these bespoke feeds of data that it uses to do these analyses that aren't representative. It's not a truly representative national sample. So back in April, when CDC said there were 4,000 people hospitalized with COVID, they had no idea. What they were doing was they were taking a sample from 1,000 of the nation's 6,000 hospitals and modeling how many people they thought were hospitalized with COVID. Now, you would think something as straightforward as how many people are hospitalized each day with COVID could be tabulated. They said it was impossible. There's actually a quote in Science, the journal Science, where the CDC said it's impossible to tabulate how many people are hospitalized with COVID. The task was taken away from them. So the department set up a different unit to start collecting this information inside the Medicare program. And now we have a very reliable sample set on how many people are hospitalized each day. But CDC didn't want to move away from its traditional approach to modeling these things. And the rub became when we had the drug remdesivir, a drug that seemed to be effective and for hospitalized patients, but was very scarce. We had to make allocations decisions about which hospitals would get it, but we wanted to do it based on where patients were hospitalized. And Deborah Birx at the time said, I can't send a scarce drug to hypothetical patients that are modeled off of an estimate. I need to know where patients are actually being hospitalized, especially since different parts of the country are experiencing this wave of epidemic spread differently. CDC's sampling didn't include the whole northern half of California. I mean, their sampling was very sporadic, so they had poor sample sets. If you go to the CDC website right now and you type in how many people died of flu in the 2017-2018 flu season, It was a particularly bad flu season. It's probably about 80,000, it says on the CDC website. But if you actually look at the data, it will say something between like 60,000 to 120,000, or 50,000 to 120,000, because they don't actually know how many people died of flu. They model it off of a small sample set, and the confidence interval is very wide because their sample set's small. This is how they normally conduct epidemiological work. It's okay for getting a baseline in normal times, but if you're in a crisis and you actually have to know where the infections are occurring, it's not very effective.
I do want to get people's questions in soon, but I have a couple of more questions for Scott before I open it up for all of you guys to ask him questions. I remember back at the height of the first surge, the March, the April, I just remember waking up every day and just feeling sort of doom and helplessness, and thinking that we were all sitting ducks, and at least those of us who had to leave the house every day, which I was, and going into the city, that it was just a matter of time before I was going to catch it. I mean, it's such an invisible threat. It's so impossible to know, was it coming off a surface? Was it because I was this close to somebody? And so I just remember feeling totally helpless, and it was a horrible feeling, and I think that so many people in the country felt that way. And so, you saw what people were resorting to, stockpiling toilet paper. I mean, these were the things that made us feel a little bit more empowered. But for everybody listening, I mean, when you describe that the CDC can't really live up to what we're tasking it with, what are normal people who are listening to this, what can they do? What are we supposed to do to take back our power, to make sure that we're prepared for the next pandemic, or that we're going to get through the next wave of COVID-19?
Yeah, look, I think we're in a better situation now in terms of the capacity to understand what the social and geographic compartments of spread are. Like, how is this spreading? What can we do to mitigate risk? We now know it's not really spreading from contaminated surfaces. It's spreading through aerosols more so than droplets. So the sources of spread end up being confined spaces with poor air circulation, where you have sort of the wrong person in the wrong place at the wrong time, someone who's pre-symptomatic, so they're maximally contagious, in an enclosed environment with poor air circulation where they're talking loudly. So I've just described a bar and a restaurant, by the way. But I think the challenge early on was that CDC wasn't able to do the analytical work quickly enough to inform us on what the risk factors were for spread. And then when they did it, it was poorly informed. The one study that I remember vividly, and I talk about in the book, is they put out an analysis in the summertime, and it was an analysis of what people did in 2 weeks preceding their infection, trying to ascertain what were the risk factors. And they found that a very high proportion of people who became infected ate out in restaurants, and it was statistically correlated. And so the headline was, eating out is a risk factor for getting COVID. But in the study, they didn't ask the people if they ate indoors or outdoors. It was the summertime, and that could make a big difference, right? Maybe eating outdoors is safe and eating indoors isn't. Maybe eating out at the restaurant altogether isn't safe. And in the same study, they also grouped bars with coffee shops. And I asked them why they would lump bars with coffee shops, and they said because they're very similar environments. Now, I don't think that's the case. But it just goes to show how poorly informed even the guidance we were getting, even the 6 feet and the 10 feet. Initially, CDC's recommendation was for 10 feet of distance. It was the White House that actually pushed back. The head of OMB, the Office of Management and Budget, a political appointee, Russ Voigt, pushed back on CDC and said, we cannot go out with the recommendation that people have to stay 10 feet apart. It will shut down the economy. Nobody can measure 10 feet. And so the compromise was around 6 feet, and CDC ostensibly predicated that on some flu data that they had that showed that if you're 6 feet apart in the setting of flu with a droplet transmission, you can substantially cut transmission. Now imagine if that had gotten out at the time, that CDC's request was for 10 feet of distance in their guidance, and the White House blocked them. The headline would have been political interference in the CDC process, yet we now know even the 6 feet was arbitrary, and ultimately the CDC reversed itself when that was the single costliest piece of guidance that CDC issued in this whole pandemic, by the way, the 6-foot requirement, because it forced schools to shut, forced businesses to shut. But
was it right?
It was wrong. I mean, the Biden administration recognized that that was what was keeping schools shut. And when they wanted to reopen schools in the spring, last spring, they started to pressure CDC to revisit that. And CDC ultimately came out with a new guidance saying that as long as kids are wearing masks, they can be 3 feet apart. which allowed a lot of schools to open.
But is that also arbitrary?
Well, yeah, so they predicated that. They predicated that revised guidance on a study they had done in the fall where they showed that if you have two individuals wearing masks that are 3 feet apart, you can cut transmission by 70%, which begs the question, if they had that study in the fall, why did they wait until the spring to change their guidance? So it just shows you how arbitrary it all was. And if you're in a setting that's conducive to spread, you could be 6 feet, 10 feet, you might be 60 feet, and it's still going to be conducive to spread if you're in an enclosed environment with poor air circulation. So we focused on the wrong factors that were sources of these super spreading events. A lot of the COVID spread is from these super spreading events. It's not one person to 2 people. Flu spreads 1 person to 2 people. COVID spreads 1 person to 30 people. And so you need to understand the conditions that are conducive to that kind of spread. And we now do, but it took us a long time.
So what's the takeaway for people? I mean, how are people supposed to protect themselves for the next month? How are people supposed to protect themselves for the next pandemic? Who are we supposed to listen to?
Well, I mean, hopefully we'll be able to listen to the CDC in the future, but I think you're going to need an agency that, and look, they're getting better. And Rochelle Walensky, Dr. Walensky recognizes the importance of compressing the period in which they get data and start disseminating information to the public. The guidance has gotten more informed. They're starting to give this scientific rationale for their guidance more often. Even something as simple as just, if you look at an intelligence estimate, I know you do, from CIA, it'll say, we assess X. We assign a moderate degree of probability to our assessment. Here's the basis for our assessment. So the policymaker and the consumer of the information can decouple it and say, look, they're pretty certain about this. They seem less certain about this. I'm going to assign more vigor to pursuing this. CDC doesn't do that. Everything comes out and it looks like it has equal weight. They don't say, we're really sure that a mask can cut transmission, but we're not so sure about 6 feet, so that a policymaker, a mayor, or governor can say, I'm going to put more vigor in trying to get my population to wear masks. I have a limited capacity to get compliance. I'm going to put more vigor behind the things that have greater scientific certainty. CDC never did that. So part of it's how they develop and surface information. Part of it's how they communicate information to the public. A lot of that is changing, and it needs to change more. And the agency needs to be directed by Congress to do it. I don't think it's very hard to self-organize when you're in an agency around a new mission. Congress is going to have to come in and reprogram that. And the problem historically has been Congress. I was at FDA when Congress really reprogrammed FDA and improved the agency substantially. A lot of people in Congress don't understand the CDC as well, so there's fewer people on Capitol Hill who could write specific legislation on trying to reform the agency. So it's going to take some outside experts putting together commissions and things like that to come up with a set of recommendations on how to improve the infrastructure.
Okay, let's open it up to our audience.
I don't think I left you any more comments.
No, a little bit. I mean, you have certainly, I think, outlined for us the problems at the CDC and how we got into this mess. But in terms of fixing it, it sounds like it's going to be a while. It's
going to be a while. I think, look, people say, we better prepare today. We're better prepared today, number one, because of the technology. We've kind of crossed this threshold where we can now derive drugs and therapeutics using fully synthetic techniques that don't require you to get and grow with the virus. You can use sequence data alone. I think we're better in terms of our preparedness, our infrastructure, because we recognize what the shortcomings are, and that's pretty profound. It's pretty important, knowing what you didn't do right. But I don't know that we've really done much yet to fix it. And I thought that this book would come out in the middle of the debate when Congress was convening those commissions and doing all that preparing for the next pandemic. And we haven't really started that in earnest yet. And it could be because we're still in the middle of the current pandemic. It's a hard conversation to have. After 9/11, we started the work of how to better prepare the homeland for the threats that we perceived right away. And I think it was because the threat seemed more pervasive and omnipresent. I think here there's a sense that we're dealing with COVID and the threat of the next pandemic is sort of a ways off and we don't need to grapple with it right now. That's probably true. We hope that's true. But there are some conditions that COVID has set up that make us perhaps more vulnerable. Like, we haven't put flu immunity in the population for 2 years. It's going to set us up for a whopper of a flu season at some point.
On that note. Okay, Jennifer, I know you have some questions from the audience.
Thank you both very much. For those of you who are in the library today, we ask that you stand at one of the 2 microphones on either side of the auditorium, the forum, for you to ask your questions. That way everybody at home watching can actually hear your question as well. And we ask that you keep your mask on as you're speaking into the microphone. It will pick you up. I also have some questions from folks at home. So I'm going to start with one from home, and then we'll go to in-house questions. Sarah would like to know, we had a small window where we felt protected from the vaccine, and now we are seeing breakthrough cases. Will we ever reach a point where we feel protected from the vaccine?
Yeah, I think so. Clearly we've seen evidence of declining vaccine effectiveness, particularly in older individuals. A lot of that data is coming out of Israel. We're seeing in the data coming out of Israel that the third dose, the booster, seems to restore immunity on par with what our initial expectation was for the vaccine, 95% protection against infection, severe disease, and hospitalization. Whether or not that persists for a longer period of time, I think that there is reason to believe it could. We don't know yet. We don't have long-term data, but there is this concept of immune rest, and the more that you have a long interval between dosing with a vaccine, the more that you're going to induce a longer-term immunity. There's a lot of vaccines where it's a 3 or 4 dose regimen, so this wouldn't be highly unusual if it required 3 doses of this vaccine to try to induce a longer-term immunity. And it may be that over time we're going to learn that if we space the first 2 doses apart, that'll also induce a longer-term immunity. Early on, we were optimizing the vaccine development. I'm on the board of Pfizer, as many of you know. We were optimizing for trying to get the trials done very efficiently and also trying to get the population immunized as quickly as possible, get as much immunity to the population as quickly as possible, because we were in the middle of a raging epidemic. So we didn't optimize. We didn't ask the question, what's the longest possible interval you can wait between the first 2 doses to induce the longest possible immunity? That wasn't what you were optimizing for. The question was, what is the most efficient interval that you can administer the first 2 doses to get a maximal amount of immunity into the population as quickly as possible? So it may be that we extend the interval between those first 2 doses and you get a more durable immune response from those 2 doses and then from a subsequent booster. But setting that aside, I still think that there's a likelihood that this ends up being an annual vaccine, at least for some portion of the population, because we are going to want to evolve the vaccine, I think, over time. We're 2 strains removed, 2 generations of coronavirus removed from the strain on which these vaccines were predicated, the Wuhan variant. We had the Wuhan variant, then we had B.1.1.7, now we have the Delta variant. And so we're pretty far evolved from the original strain on which this vaccine was constructed. The fact that it still works so well is encouraging. It suggests that the immunity that we derive is more durable, and it's going to hopefully remain durable. But we're probably going to have to revaccinate at least a portion of the population on some regular schedule, maybe on an annual basis.
Great, thank you. Sir?
You've probably seen Michael Lewis's book, The Premonition. I don't know if you had a chance to read it.
I have, yeah.
But he makes the point that there's an institutional problem in government, that that nobody in government is ever penalized for not doing something. They're generally penalized for doing something. And he suggests that the CDC has been essentially reluctant to take action since the 80s, when Reagan removed the commissioner of CDC and Congress passed legislation that made the CDC subject to presidential oversight. Would you care to comment on that?
Yeah, I don't think that the fact that there's politically appointed heads of these agencies, and I was a politically appointed head of the FDA, makes them any more or less likely to act with conviction. In fact, I think it probably makes it more likely that they're going to act with conviction, because if you're a strong political leader of an organization, you feel like you have latitude to act, and then you can get support of the administration and Congress as a politically appointed official, as opposed to a career official. I do believe that. It's sort of dependent upon who's leading the organization. So I don't think that that's the root of the issue. I think the root of the issue is, you're always in a position of either overreacting or underreacting to a emerging crisis. I remember, and it's going to sound like sort of small ball relative to the kinds of things that we dealt with right now, but during outbreaks of foodborne illness when I was at FDA, we always struggled. So I remember very vividly it was about 2 days before Thanksgiving, and my wife's up there, she'll remember too. I recalled all the romaine lettuce in the country. 2 days before Thanksgiving. First phone call I got was from my wife about what she does with the salad she just made. And the reason we did that was because we had cases of E. coli and romaine lettuce. We had some deaths associated with it. And we knew that there was only one region of the country harvesting at that point, the Salinas Valley in Northern California, and they had just done their harvest. And what we knew was that the romaine lettuce that was contaminated probably came from the Salinas Valley and probably was still on store shelves. So by recalling all the lettuce immediately, we could interrupt the propagation of the infection. We could actually potentially save lives. Normally, when you find out about an outbreak of foodborne illness in a food product, it's well after the fact. You're doing an after-action investigation, and the food product has been distributed and eaten, and the illnesses have occurred. This was one of the rare cases where we could intervene to actually affect the action. That was extremely controversial. I was heavily criticized for it at the time because people were saying I overreacted, I destroyed the romaine lettuce industry. First phone call I made after that was to Jimmy Panetta, first-term congressman from Northern California, Leon Panetta's son, because it was his district, and I wanted to let him know what we did and why we did. I knew he was going to get phone calls from angry farmers up there. But you know, those are hard moments because you wait 2 days and it's Thanksgiving, and you have many more people that have become sick and some who will potentially die. You recall all the lettuce and you're wrong. It was a confined outbreak, a single farm, or maybe it was coming from another part of the country. There was some hydroponic romaine lettuce facilities that were also harvesting in North Carolina. And you're wrong, and you're blamed for destroying the industry. So those are very hard moments. This was an order of magnitude worse than that in terms of the ability of policymakers to make decisions. I think a politically appointed leader who feels confident in their role, confident that they have the support of the administration and Congress or can muster it, confident that they can communicate it effectively to the press is going to be in a much stronger position to make those hard calls. So I don't think that is career versus politically appointed. I think it's sort of person dependent, and sometimes a political leader is in a better position because they're going to be able to push back on some of the political criticism that they get.
Sir, on that side?
Dr. Gottlieb, I wanted to ask you about regulatory failure as it relates to rapid at-home self-tests. As you know, here in parts of the US, it can be difficult to find these tests. They can be relatively expensive, upwards of $10 a test. Whereas if you compare this to, say, Europe, they're basically swimming in these tests, and they may cost an order of magnitude less. Now, Harvard epidemiologist Michael Minna argues that it's because we're misregulating these tests, that we're regulating them as medical diagnostic tests, in which sensitivity and specificity to basically any amount of viral RNA is paramount, when we should be regulating them as public health tests, where we care about sensitivity and specificity to contagiousness, and further, that accessibility, frequency, and turnaround time are actually more important than the super high specificity and sensitivity you get with PCR tests. Do you agree with this? If not, why not? And if so, what can we do to change the regulation, get more of these public health tests out and accessible in the public and help end transmission chains?
Yeah, I mean, he argues that they should be regulated as public health tests for screening as opposed to for diagnostic, as a medical device for diagnostic. I think we failed to use at-home diagnostic tests effectively all through this pandemic. I think things are changing now. The market's different now. But we failed to use these early on. The op-eds I talk about in January, where I was advocating for the development of at-home tests, antibody-based tests that could be basically lateral flow tests, self-swabs. We finally have them. This is one place where FDA has undergone a dramatic cultural change over the course of the pandemic. There was a view in the agency when I was there that you shouldn't make a test available to a patient diagnosed at home with an infectious disease, especially a reportable pathogen like COVID, because first of all, you want to make sure they get into appropriate medical care. If they self-diagnose at home, they might not. You want to make sure the result gets reported to public health authorities. The agency has made a wholesale change in its view of this, and this is going to open up an entire market for home diagnosis of a range of things: flu, strep throat. I mean, the way we diagnose minor illness now is going to change dramatically. When I was at FDA in 2003, the debate was over home HIV testing. There were a group of us, including myself, who were advocating allowing a diagnostic test to come to the market that would have allowed you to diagnose for HIV in your home. And there were a lot of people against it. They felt that the diagnosis of an HIV infection is such a dramatic diagnosis that you want to make sure a person has proper counseling. You want to make sure they get into appropriate care immediately. And some of us felt that the goal should just be to get more people diagnosed. Sure, we might miss some people to follow up, but if we could just get more people diagnosed, we're going to get more people to treatment, and just self-awareness of an infection, people will take action to prevent further propagation of the infection. That was the old paternalistic view of FDA. You've seen sort of a dramatic shift in the agency. So you're now seeing these tests enter the market. The shortages are around the tests we like. The Binax now is an easy-to-use test, and I have no relationship to Abbott, but I use the Binax test at home. But it's expensive, $25 for a box of 2. The Kydal test, which is also an at-home test, a little bit more cumbersome to use, so consumers don't like it. The Lucera test, which is a molecular test for at home, is $50 a test. And a lot of the other tests where you can self-swab, you have to send it off, and people don't want that. Or you have to upload the result to an authority and then get the answer back, and people don't like that. They want the privacy of being able to turn over the positive test themselves. So it's not that we don't have tests. We don't have the tests that consumers prefer, and the ones that they prefer are the ones that are in shortage right now. But I think that temporary shortage situation will be resolved as businesses recognize what consumer preferences are and more of the investment goes in those kinds of tests. It's still expensive. I think there's much more the federal government could be doing to subsidize the availability of tests, particularly to people of lower income who are working essential jobs where they can use testing as a way to protect themselves and their families more effectively if they had access to more tests. That's what they're doing in the UK. Tests are cheaper there overall. We probably have on that $25 is probably like $10 of regulatory costs and another $5 of legal, liability costs loaded into that test because we are who we are in this country. But I think we could be doing more to subsidize the delivery of tests, certainly to parts of the community where testing could be a much more effective tool and where they are priced out of the ability to serial test, like certainly in the Medicaid program. I don't know why we're not doing that.
Great, thank you. Sir, you can go ahead.
So first of all, thank you for being a down-the-road moderate voice. I watch you all the time on CNBC, and I think you're a really welcome breath of fresh air. 2 quick questions for you, if I can. One, when we look at the number of cases now, 100,000 a day or 120,000 a day, how does it compare, if we compare it to previous peaks, but there's 100,000 people at football games every weekend, and outside of Fairfield County, a lot of people aren't doing what they were doing a year ago or 6 months ago during the previous peaks, and they're not wearing masks like we are. How do we evaluate the 100,000 cases now versus what it was? Like, is it less severe because people are doing so much more and are out so much more now than they were? And then secondly, why aren't people reporting more the likelihood of severe illness for people who are vaccinated? I feel like it's not, you read articles that say 41% of the people that are getting really sick who are vaccinated have cancer or other pre-existing conditions. Why isn't that amount being reported so that we, who many probably are vaccinated and are wearing masks, would feel a little bit safer?
Yeah, CDC made a decision to stop recording breakthrough infections that happen in the outpatient setting. So they're only systematically collecting data on breakthrough infections, people who are vaccinated and develop an infection who get hospitalized. They have these, what they call these cohort studies that they're using to evaluate vaccine efficacy over time. So the discussions, when Pfizer came out with a statement that they were going to pursue boosters, and CDC put out a statement immediately saying, not so fast. CDC kept saying, we have data that shows that there isn't declining vaccine efficacy. And they kept saying, we have data, we have data. They said it on phone calls with FDA, and everyone said, okay, show us your data, because we're looking at data from Israel that shows declining vaccine efficacy. And turns out the CDC data are cohort studies where they've followed groups of patients, tens of thousands, not hundreds of thousands, but they follow specific groups of patients over time who've been vaccinated to see what the rate of breakthrough infections are in those patients. They do serial testing. But their cohorts are nursing home patients, healthcare providers, grocery store clerks. They specifically follow groups that they knew were at high risk of infection. But the problem with that is that being at high risk of infection, they were probably infected, more likely to be infected before they got vaccinated. So they're not a representative sample of the population, because we now know people who are infected and get vaccinated develop a very robust immunity. So seeing seeing less breakthrough infections in that group doesn't really tell you what's going to happen in sort of the normal population where you have people who are less likely to have been exposed to the virus early on. But that's why we don't have this information. If you talk to the doctors, you talk to the hospitals, they'll tell you about 90% of the people hospitalized are people who are unvaccinated. So it still is very much that the people who are getting sick are unvaccinated. But I suspect that there's a lot more mild and asymptomatic infection happening among vaccinated individuals than what we're detecting. And that's important because the vaccine is doing its job, is protecting people from getting sick and getting very sick. But if you have a vulnerable relative at home, if you have young children who are unvaccinated, it's not comforting to know that you as a vaccinated individual can still bring the infection into that setting and still be at risk of transmitting it. Even though you might be at less risk of transmitting it, you're still at risk of transmitting it. So we should be gathering better data around that. The data that we're relying on is the Israeli data set and to some degree the UK data. But the UK data probably isn't truly representative of the US experience because they had a much longer interval in terms of how they administered their vaccines. And that may have made the immune response that they got from the vaccines a little bit more robust. In terms of the cases that we're seeing now, probably in the early phase, the first wave of the epidemic, the New York wave, we were probably diagnosing 1 in 20 infections. By the winter time, we were probably diagnosing 1 in 3 to 1 in 4. I wouldn't be surprised if, at least for the southern wave of Delta, we were diagnosing 1 in 10. That diagnosis went way down. There's been 43 million cases of COVID diagnosed in this country. My guess would be we're only diagnosing overall through the whole epidemic at best 1 in 3, more likely 1 in 4 infections. If you go with 1 in 4, then you get to a number where half the population has had COVID. So that's why I think we're approaching levels where there's so much immunity in the population, either from natural infection or vaccination. At some point, this is going to collapse and prevalence will decline.
Going to a question from the audience at home. Do you think masking and seasonal precautions will remain a part of public health culture in Connecticut and elsewhere on a more permanent basis?
I don't think you'll have mandates in place on a permanent basis, but I think our culture is going to change around the risk of respiratory pathogens in the wintertime, and it's going to have to because we can't be as complacent about as we've been about flu in the wintertime with the twin risk of COVID and flu circulating. I think at best, COVID is going to be a second circulating flu in terms of its overall impact on death and disease, at least for the foreseeable future. And the problem is we already have a flu. And so if you have COVID circulating alongside flu, I don't think that we could be as cavalier about the risk of respiratory disease, crowding people into rooms, not having good air filtration in confined spaces, coming to work when you're not feeling well. So I think work life is going to change a little bit. It won't be dramatic. I mean, it will start to feel normal. It's not like our whole society has to be upended, but I think we're going to have a veneer of safety around respiratory disease that we didn't have before COVID because of the twin risk of COVID circulating alongside flu, at least for the foreseeable future. Trevor Bedford, a very good genetic epidemiologist who basically created a whole new genre of using sequencing as a way to augment traditional epidemiology in the setting of COVID, just won the Howard Hughes and became a MacArthur Fellow just in the last week. He predicts that we'll have probably 80,000 deaths a year from COVID. 80,000 deaths puts it on par with a bad flu season. And so you're going to have to do things differently with that kind of risk circulating. One of the studies I remember vividly from my medical training was a study that looked at, it looked at people who wore masks in public. And it assessed how far other people stood away from you. And what it found was that if you had a mask on average, people would stand further away from you because they would assume you're sick. I think now masks are going to become more commonplace culturally, and people won't assume that you're infected. They'll just assume that you don't want to get infected. So it's going to be more culturally acceptable to have a mask on in an airport, and people won't look at you funny.
But quick follow-up, how long do you think we'll all be wearing masks like this?
I think on the back end of this Delta wave that we're going to sort of reassess. Once prevalence comes down, I mean, prevalence is low in Connecticut right now. Really, we're at levels where we were unmasked. I think a lot of what we're doing right now is on an assumption that things are going to pick up, and we're seeing what's happening around the country, and it's not an unreasonable position for public health authorities to take. I think when prevalence comes down around the country, hospitalizations come down, people are going to feel more comfortable. The ordinances, the mandates will be lifted. what we're going to be looking at in the future isn't just cases. We need to get away from looking at cases as the measure and looking at the overall impact on society. How many people are being hospitalized? How many people are succumbing to the infection? And I think that's where we're going to see dramatic improvements because of the improvements, in vaccination rates, because of the fact that we'll have orally available therapeutics. The monoclonal antibodies are being formulated in subcutaneous formulations where they can be delivered as an injection in the doctor's office. They're highly effective. I mean, our therapeutic toolbox by the end of this year is going to be substantially different, and the advent of home testing. I mean, when people now feel sick, they're going to test at home. Mm-hmm. And, you might have a requirement to bring negative tests, to have a negative test to prove that you can re-enter a venue after an illness. So, our practices are going to change around this. That I think is going to protect a lot of environments.
That's great.
In the red coat, please.
Thank you. It was in the news today that New Zealand is changing its policy and is going to kind of allow for living free rather than shutting down society. Is that a potential thing that can happen here, or are we too big to do that in this country?
Well, I think what you're seeing in some of the other nations is as their vaccination rates creep higher, they're moving away from their zero COVID policies where, New Zealand and Australia have basically sealed off their countries. Even China is building mass quarantine centers. People wonder why they're building mass quarantine centers. They're doing it, my understanding is they're doing it based on an expectation that they're going to start to reopen the country to travel. And as they do, there's going to be more cases. They're going to identify more cases, have to quarantine more people. So I think you're seeing a rethinking of the policies of the last year and a half in a lot of countries that try to adopt a zero COVID policy on a premise, number one, it's unsustainable in the long run. Number two, now that they've achieved higher rates of vaccination, they've protected more of their society, they can now tolerate some level of spread. We never had and never can have a zero COVID policy in this country. I mean, there's just too much infection already, and our society is too open. But I think that's partially reflecting what you're seeing in New Zealand.
Great, thank you. Sir?
Yes, I have a couple of questions. The first relates to something you alluded to earlier. When the first
Excuse me for just 1 second. If you could just keep it to one question, we still have a lot to go through.
Okay, sure. The first, when the first variants became evident, there was a lot of talk about how susceptible the mRNA vaccines were to modification, and that there would probably be vaccines for the Delta variant, for example. But we hear very little about that now. Are those vaccines being studied? Why don't we see those now? And will we see those in the future?
Yeah, I mean, I can speak for Pfizer a little bit. So Pfizer is developing, every time a new variant comes along, you start, and I'm pretty sure Moderna is doing the exact same thing. You immediately start developing a vaccine construct based on the new variant. And Pfizer is actually fully developing, doing clinical studies on a Delta variant vaccine. The decision, and so that's going to be ready. And it's going to be, and the company is going to start some level of commercial scale production, not massive production of it, but basically the building blocks of being able to pivot to do that. And the virtue of the mRNA process is that it's basically plug and play. In the old way of making vaccines, you have to, so let's take flu, for instance. Let's take H1N1 in 2009. We got the H1N1 strain. We isolated the virus. We had to figure out how to grow it in cell cultures, in this case, chicken eggs, figure out how to get a good yield. So you had to modify the virus to be able to get it to grow effectively and efficiently in chicken eggs. And that actually was the rate limiting step. We weren't getting as good yield from the eggs as we normally would with a flu strain. You harvest the virus from the eggs, you inactivate it, you cleave off its surface proteins, and that becomes the vaccine stock. With the mRNA process, it's basically plug and play. You have this enormous manufacturing facility to churn out mRNA-based vaccines. If you want to change over the vaccine to a new strain, you don't have to figure out how to grow that strain in a cell culture. You just get the mRNA sequence and you plug it into your manufacturing process, and your yield is exactly the same. Much more stable, predictable manufacturing process. So that's the virtue of it. The decision around will we switch over to a Delta backbone vaccine is going to have to be made by global public health authorities. So with flu, we have meetings each year organized by the World Health Organization, where all the top experts around the world come together and decide what strains are going to be in the flu vaccine. Once they come together for the Southern Hemisphere, once they do it for the Northern Hemisphere. Then there's, I think, 6 labs in the world that start developing the seed stock that's going to go into vaccines, and then they ship that to all the vaccine manufacturers, FDA being one of those facilities. There's one in Australia, there's one in Russia. We have no infrastructure and process like that. I just texted someone very senior in the government, public health authority, and I said, so have we started to talk about the process for how we're going to make a decision about switching over the vaccine? And the answer was not yet. Now, it's not too late to do that. I think we need to do that by the spring. I think we first of all, we should be deciding what the process is going to be to bring together global public health authorities. And by the spring, we probably need to make a decision if by the fall we want to switch over to a Delta variant vaccine, because you want to start manufacturing it at scale and stockpiling some of it. You don't want to just do it right on the eve of when you're going to be distributing it. So we need to start that discussion more actively right now about how we create a global process for making decisions about if and when we switch over to a new backbone for the vaccine. I think we will. That's my personal opinion. I don't know that everyone shares it, but I think that given the fact that there is more and more reason to believe that any new variants are going to be within that Delta lineage, it makes sense to have the Delta virus be the backbone for future vaccines.
Thank you.
Great, thank you. So I'm going to end with one question from the at-home audience, if you don't mind. Might you consider running for president?
I don't think I'm cut out for elected office, so thank you. Thanks a lot. Thanks for coming today. Thanks for doing this.
My pleasure. I learned so much. This will be super helpful on my program, particularly if you come on.
I'll keep the answers shorter.
Great, thank you
Great.
both
Thank
so
you
much
guys all.
for this evening. Thank you
Thanks
all
a lot.
for coming.